Today, I want to share with you guys a case of a recent patient that I admitted. And before we get started, I wanted to take a quick second to thank my very first supporter of the channel, Lemon Drops, who signed up for the new memberships function on my website that I just set up. So this is something that I honestly just set up last week for people to support the channel if they're interested, and then maybe receive a few perks or benefits on the side. And basically right after I posted this on my website, he immediately signed up for the Ultralisk tier, and his comment for me was, "Thank you so much, love your education content." So I just wanted to say a very huge shout out and thank you to Lemon Drops for being my very first supporter. I've taken the liberty to edit or modify some aspects of the case to protect the patient's identity, but basically this is a 65-year-old man with cirrhosis presenting with the chief complaint of dark stools and coughing up bright red blood for the past 3 days. So I think immediately you guys may already have some alarm bells going off. So when they're talking about the dark stools, is he referring to melena, which would be indicative of an upper GI bleed? And coughing up bright red blood, is he referring to hemoptysis, or could this actually be a manifestation of hematemesis, potentially from one of the complications of cirrhosis that we talked about, like esophageal varices? The rest of the HPI is not too much more revealing. So aside from his primary concern of the dark stools and coughing up bright red blood, he's endorsed some poor PO intake, fatigue, shortness of breath. He also reports diffuse body pain for the past 2 weeks in the abdomen and behind his breasts. He didn't actually want to come in, but his wife told him to. And he's hoping that he doesn't have to stay very long because he has a hepatology appointment in a few days, which he's especially hoping to make because they're going to be evaluating for liver transplant. In terms of his medical history, he has untreated hepatitis C, he has HCV cirrhosis, has been complicated by ascites, required 1 paracentesis a year prior, as well as hepatic encephalopathy, 1 prior episode as well, which was during that same admission. He's had esophageal varices, status post-banding. At that time was 6 varices, which were banded. He has diet-controlled type 2 diabetes, and a recent admission 3 weeks ago for concern for upper GI bleed, underwent EGD at that time, which showed only 1 small esophageal varix and portal hypertensive gastropathy. Social history, lives with his wife at home. He's independent, ambulatory, without assistive devices, however, has been struggling to make it to the bathroom recently due to increased shortness of breath. No drug or alcohol use. Family history is non-contributory. Past surgical history, also non-contributory. And then for medications, he's on fluoxetine, 20 milligrams daily, Lasix, 20 milligrams BID, spironolactone, 25 milligrams daily, lactulose, 45 grams TID, and rifaximin, 550 milligrams BID, pantoprazole, 40 milligrams daily, and trazodone, 50 milligrams QHS. Looking at his initial vitals, his temperature is 97.5, blood pressure is 120/64, heart rate 86, respiratory rate 18, and he's satting 94% on room air. For his physical exam, he's a pleasant man, somewhat chronically ill appearing and fatigued, but no acute distress. His cardiac exam is notable for a loud systolic murmur at the left upper sternal border, otherwise regular rate and rhythm. Lungs are clear to auscultation on the right, but diminished on the left. Abdomen is soft, but distended and diffusely tender to palpation. I did a point of care ultrasound, which showed about 2 centimeter pockets of ascites, no lower extremity edema, and his neurologic exam was normal, ANO times 3 with no asterixis. Now we can take a quick look at his labs. So his white count is 2.6, hemoglobin 11.3, and his platelets are 92. This hemoglobin is actually higher than his prior baseline, which seems to be around 10 or maybe the high 9s. The leukopenia and the thrombocytopenia are also at baseline. In terms of his basic metabolic panel, he has a slightly mild hyponatremia, otherwise not too remarkable. His LFTs are notable for a protein of 9.2 and albumin of 2.8. AST and ALT are somewhat elevated in the 100s, although this was similar to his prior admission just 3 weeks ago, and the alk phos was mildly elevated as well. His A1C is 6.8, his TSH is 5.91 with a free T4 of 0.89, and 3 weeks ago they checked his iron studies because they were concerned for the upper GI bleed, and he had an iron of 63, an iron sat of 19%, and a ferritin of 142. Interestingly, and I couldn't really find any documentation on why this was checked, but he had an autoimmune kind of panel checked that was pretty positive for multiple different things. So he had an ANA of 1 to 160. There was also a positive cytoplasmic pattern with a titer of 1 to 80. And his double-stranded DNA was positive at 1 to 160. Also had positive ANA by HEP2, which sometimes they use to confirm if it's a true positive ANA result. And then also had an anti-SSB that was slightly positive. So interestingly, here's his chest x-ray on admission as well. And he was noted to have a moderate to large left-sided pleural effusion. And when I actually went back to his imaging 3 weeks prior, he also had a CT scan and a chest x-ray at that time, both of which were showing this left-sided pleural effusion. It was just never addressed at that time. So the way that this patient was sold to us as an admission is for a possible GI bleed, assess for clinical stability, see if he potentially needs another upper endoscopy to figure out what's going on, right? His chief complaint is the dark stools and coughing up blood for the past 3 days. However, I think there's a few things that maybe make a GI bleed a little bit lower on the differential at this point. Or at the very least, maybe just not our primary concern at this point. All right, and before we move forward, I actually want you to take the time to pause the video and potentially come up with your own problem list. How would you prioritize the different problems that this patient has right now? What do you think you would order, and what do you think your plan would be for the different problems? Try to come up with your own list, and then I'm going to come up with a list here, and then we can take a look to see how your list compares to mine. So if we go down here, we can start building our problem list, and this is what you'd be doing kind of real time as you are admitting a patient. So problem number 1 is kind of our concern for GI bleed. Now, what are some of the things that are arguing against an active or very significant GI bleed at this point? So I would argue one of the things is actually seeing his heart rate at 86 is pretty reassuring that he's not having an extremely brisk GI bleed, because one of the first changes that you're going to see is tachycardia. Even before you see blood pressure start to drop, tachycardia is the first sign of a brisk bleed that's going to be going on. And his blood pressure being good also is reassuring. This hemoglobin, like I said, his baseline was maybe in the low 10s or so. So being a little bit higher is, again, reassuring, but we probably still want to trend the hemoglobin just to make sure, because during an acute bleed, you actually can get a little bit more hemo concentrated in the acute phase. And then once you give fluids, then you'll see the real drop in the hemoglobin. But so far, this is a reassuring sign. I think the fact that he had this recent admission 3 weeks ago and had an endoscopy at that time, which only showed one small esophageal varix and portal hypertensive gastropathy, was also very reassuring, because he's had quite a few varices in the past, but with such a recent EGD, our concern for like a really brisk esophageal variceal bleed is going to be very low because of this recent EGD. And that's the thing that scares us the most in these patients with cirrhosis, is these esophageal variceal bleeds, which are very, very dangerous with very high mortality. And finally, some things on his BMP. So the fact that his BUN is normal. Now, if we're seeing some chronic ongoing slow bleeding, usually you are going to start to see an elevation in the BUN, because blood has a lot of nitrogenous products. And if you are slowly bleeding, you may start to see your body start to digest that blood, and it will cause an elevation in your BUN. And also, we even see that his iron studies last time also kind of argued against this chronic slow bleed process as well, because he actually had decent iron stores. So regardless, what would you want to do if this patient was admitted? Well, I think this is still his primary, reason for coming in, is this hematemesis potentially, and possible concern for melena. So what we would do is probably just start him still on an IV PPI, BID, just in case this is an upper GI bleed. we're probably going to trend his CBCs, and I opted to trend it Q8 hours because I didn't feel like, we needed to do it that quickly. And then after, 12 hour, after a couple checks, if it's all stable, they can start to space it out after that. We are going to start ceftriaxone for SBP prophylaxis, because anytime you have a possible GI bleed, we're going to want to do ceftriaxone for SBP prophylaxis. And then decided to hold off in this situation on octreotide, which would be kind of our next step if somebody was having a variceal bleed. Again, because our concern for variceal bleed was lower. I forgot to mention, we were also going to check the INR daily, and also, involve GI if a higher concern for bleed occurs, and that we think that he does need a repeat endoscopy. We'll consider GI consult if suspicion increases. Okay, but what would you say at this point his next problem is? So we have a couple of other things on his history that maybe this GI thing isn't really his main problem, but potentially there's some other things that we need to optimize here. So what do we think about his shortness of breath and this pleural effusion that we're seeing here? What do we think about this diffuse body pain in the abdomen and behind his breasts? How do we think about his cirrhosis regimen, Lasix 20 BID, spironolactone 25 daily? How does that all look? And then what do we make of this autoimmune workup that was obtained last time for unclear reasons? It's a fairly decent titer, 1 to 160, and dsDNA is positive, anticytoplasm is positive, SSB is positive. So why don't we continue to build out our problem list here, and let's put problem number 2, and that's going to be the abdominal pain that he was reporting, or the whole body diffuse abdominal pain. And in this case, I basically wrote that we needed to rule out spontaneous bacterial peritonitis. Again, if you remember the video that I posted earlier in the week, any patient that comes in with cirrhosis and with ascites rather, even if they're coming in for another reason, they should warrant at least a diagnostic paracentesis on admission to rule out SBP. In this case, this patient actually was experiencing pretty diffuse abdominal pain, and so that even further raises the concern for SBP, although he did not have a leukocytosis or a fever, which may have been other clues that they would have had. So basically, this person is going to need a paracentesis. Unfortunately, I was unable to do it at bedside because he only had about 2 centimeter pockets, and generally I look for about 4 centimeter pockets in order to safely do it at the bedside. So in this particular situation, we are going to probably call IR in the morning to try and get this. Another thing that kind of complicated this is that he already received ceftriaxone before the paracentesis was done, before I even saw the patient. And so that potentially may decrease our yield. So in these scenarios, potentially we may just want to treat empirically for a full course of SBP prophylaxis for 5 to 7 days, because the neutrophils of greater than 250 may not be present, considering he already got antibiotics before the para was done. I didn't decide to treat with albumin at this time because we didn't confirm that it was SPP yet, but that is another consideration that you could think about. The other thing that I wanted to address is possibly the breast pain that he was reporting. He did tell me that he was having all over diffuse body pain, but it was in the abdomen and in the breasts. And he was saying that he was feeling some kind of hardness behind his breasts. And possibly I was thinking this could be from spironolactone. And so I did kind of let him know that gynecomastia is one of the potential side effects of spironolactone. So that was a question mark that I had on this admission. And then the next problem moving forward, so why don't we address his moderate left pleural effusion. So this one's actually quite interesting, and it was seen on the prior hospitalization, but wasn't really addressed at that time because it seemed like he was really just there for a GI bleed. So I think it just kind of got brushed to the side. But coming in here, that was something that was very curious to me when I saw this left pleural effusion. So typically, if I were to see a right-sided pleural effusion, I would not be very concerned at all. In fact, I would be almost certain that it's hepatic hydrothorax. But when it's on the left side, it's a little bit odd. It's weird for somebody to have a left-sided pleural effusion from ascites. So if it was just on the right side, yes, it may still warrant a tap at least one time to just confirm that it looks like hepatic hydrothorax. But the fact that it's on the left side, in my opinion, makes it definitely something that we need to tap to figure out what the etiology of that is. Because anytime you see a unilateral pleural effusion, it really warrants being tapped. If you see bilateral pleural effusions, well, then usually that's a volume issue, and we need to just diurese and see if we get symptomatic improvement or if we get clinical improvement from that. But definitely this would warrant tapping, in my opinion. Again, this could be something you could do at bedside, but at my academic institution, typically us hospitalists are not doing thoracenteses because of some protocol that was established many years ago. But usually we're going to be calling IR or pulmonology for a thoracentesis. And let's talk about now this positive autoimmune workup. It's kind of unclear what's causing this, but I'm just going to say, you could say positive autoimmune workup, or you could even say concern for lupus. Although it sounds weird, right? Lupus should be, a younger female patient would be the most common, demographic that we see, especially on board exams. But this patient is in their 60s. They have no other history suggestive of autoimmune disease. He's not having rashes, joint pains. So it seems like lupus would be very, very unlikely in a patient like him. But we do need to have an explanation for why his ANA is relatively positive and his anti-dsDNA is positive as well. So if you actually look for the diagnostic criteria for the classification of lupus, there's actually this 2019 EULAR/ACR criteria for diagnosis. And so you have to meet a certain threshold of greater than 10 points to be classified as lupus. And one of the entry criterion to be considered for this is having an ANA of greater than 1 to 80. So he had 1 to 160, so he did meet this criteria. And then if we actually look at the criteria, what did he hit? So no fever. He didn't have any cutaneous findings that we found or any joint findings. Neurologic domain was normal. He did have a pleural effusion, so that gets him 5 points, but it's a little hard to tell if that would really count in this scenario because he has known cirrhosis, which could cause pleural effusions. He does have leukopenia and thrombocytopenia, giving him an additional 7 points. However, again, he has underlying cirrhosis, which could also explain both of those findings. In terms of the renal domain of proteinuria, we did check a UA, and he did not have protein in the urine. That result didn't come back until later. I did end up throwing on some of these additional studies just to round out the entire workup, since we had already kind of went down this pathway anyways. And then he did have that positive anti-dsDNA antibody, which gives him 6 points. So if we just go based off of that, I mean, he has like 18 points. However, about 12 of those points could be potentially from underlying cirrhosis. But it is interesting, and the fact that he scores 18 points on this diagnostic criteria, I think does make you want to consider if you want to get rheumatology involved to explain these positive findings. So in this scenario, I sent the rest of the autoimmune workup and wanted to consider a rheumatology consult. Now, this may seem like we are consulting so many people, but really in this specific case, it was a fairly interesting case with all of these different findings. A concern for a GI bleed or a variceal bleed, a concern for a unilateral left-sided pleural effusion, concern for spontaneous bacterial peritonitis. Autoimmune workup is positive. So we always try to avoid over-consulting when it's not necessary. But in this particular patient, I think they have a lot of valid reasons for getting specialists on board. Now we can talk about his decompensated cirrhosis and talk about the management of that. So remember, we have that mnemonic of vibes. So let's talk about V first, or volume. So what is he currently getting? He's currently getting Lasix 20 BID and spironolactone 25 daily. It's kind of an odd regimen because if you remember, we typically do a ratio of 5 to 2 of spironolactone to Lasix. So already we're seeing signs of a lot of volume overload. He's reaccumulating ascites. He's got this left-sided pleural effusion. So first of all, I think the spironolactone dose is way too low. At the very least, we should bump him up. And so I actually bumped him up to Spiro 100 and Lasix 40 daily. Instead of doing Lasix 20 BID, which is just like such a tiny baby dose, it's probably not that effective. For infection, remember we're talking about SBP, he's already on ceftriaxone, as we had mentioned above. For bleeding, we're already treating as above. Encephalopathy, He's continuing his lactulose, 45 grams TID. I think that sounds reasonable. And I think the rifaximin is kind of plus or minus here because he's only had one episode of hepatic encephalopathy in the past, which was during an episode of a GI bleed. So typically with rifaximin, I'm thinking about those recurrent episodes of hepatic encephalopathy or refractory episodes of hepatic encephalopathy. So he's somebody who's kind of plus or minus on whether he needs that or not. And then talking about screening, he's going to need right upper quadrant ultrasound, Q6 month, as well as Hep A and B vaccinations, EGD. Probably he's going to need it like every 1 to 2 years because he already has known varices. And then also, we should also be thinking about liver transplant evaluation. So as he mentioned, he actually already had that appointment set up, but just wasn't able to attend it because he was getting admitted. So what ended up happening for this patient is he ended up being seen by hepatology inpatient. And I forgot to mention his MELD was 16, and our threshold for starting the liver transplant evaluation process is above 10, definitely above 15. And so hepatology eventually was consulted for this patient. And just to round it out, his type 2 diabetes, it's well controlled. His A1C is 6.8%. So we're going to continue carb-controlled diet. We are going to start a sliding scale insulin if he becomes persistently hyperglycemic. Otherwise, I favor not doing it just because it prevents them from having to get, blood sticks every 4 hours. For his insomnia, anxiety and insomnia, he's taking the trazodone 50 QHS. He was pretty cachectic, so we had suspected protein calorie malnutrition, and this is very important for these cirrhosis patients to have adequate dietary intake. So a dietitian consult is definitely helpful, as well as just off the bat, ordering boost supplements, TID. And then he had this chronic liver injury with those elevated transaminases, which was attributed to untreated hepatitis C. So I hope this is kind of a good look at kind of the process of building your problem list and kind of the things we consider when we are making our problem list once patients are admitted. All right, so now it's been a couple days and I'm just reviewing this patient to see what's happened with them. I'm no longer involved in their care. I was just the overnight person doing an admission. But as we kind of suspected, the concern for GI bleed was pretty much knocked out pretty quickly. So he was very stable. The CBCs were stable. So he was switched back to his PO, pantoprazole, 40 milligrams daily. They spaced out his CBCs to daily, and they continued his ceftriaxone. So basically, the concern for GI bleed was very low at this point. In terms of the concern for SBP, he did end up getting a paracentesis on day 1. And in terms of the neutrophil count, it had about 60 neutrophils. Again, they treated empirically because he received antibiotics before the paracentesis was done. And then the moderate left pleural effusion, pulmonology ended up being consulted. All right, and the results are as seen here. So you can see the cell count here. He had 22,000 red cells and 541 white cells. The differential for the whites was 6% polymorphonuclear cells, 30% lymphocytes, 43% histiocytes, and mesothelial cells was 20%. Both of those are kind of non-specific. And then in terms of the other studies they got, he had an amylase of 26, cholesterol of 47, glucose of 213, LDH of 132, and a protein of 4.7. And just to get you his other results, so his serum LDH was 337, and his serum protein at this time was 8.2. So take a second to think about what you interpret these results to be, and then apply Light's criteria. So remember, what are Light's criteria? Even now, it takes me a while to sometimes remember everything, but I just kind of remember 3 numbers. So you just remember 0.5, 0.6, and 2/3. So for the 0.5, I think about protein. And then for the 0.6, I think about LDH. And the 2/3, I also think about LDH. So if pleural protein is at least a ratio of 0.5 compared to the serum protein, then that is positive for exudate. And same thing with the LDH. So a ratio of 0.6 from pleural to serum would be positive for Light's criteria of an exudative effusion. And then the last one is LDH 2/3 the upper limit of normal for their serum protein is going to be positive Light's criteria. So just think about 0.5 protein, 0.6 LDH, 2/3 LDH. And that's how you can hopefully remember how to recall Light's criteria from the top of your head. But honestly, you can just look it up whenever you need also. So he actually, in fact, did have an exudative effusion because his protein in the fluid was 4.7 and his serum protein was 8.2. So the pleural protein was greater than that 0.5 ratio that we're looking for in Light's criteria. So interestingly, at this point, they're still thinking that it could be from hepatic hydrothorax. The reason is because his cell counts are similar to that of the ascites fluid. However, they did mention that they would have expected, first of all, a transudative effusion, and secondly, they would not expect so much protein to be there because if you remember in testing the serum ascites albumin gradient, if we have low protein, that's more consistent with cirrhosis versus high protein is more consistent with a cardiac etiology. So other things that they're thinking is this could be malignancy, and what they're doing for that is waiting for cytology. And then also, if this could be some kind of autoimmune thing, like a connective tissue disease or some kind of other rheumatologic disorder. So the jury's still out on that one. What is the etiology of his left-sided pleural effusion? In terms of the positive autoimmune workup, so they did curbside rheumatology to ask them what they thought. And actually it was a very simple answer, which is probably the correct answer. But essentially, this patient has untreated HCV. And this is something that I totally forgot about, but untreated HCV can totally masquerade as a ton of different autoimmune conditions and can cause light to moderate positivity on immunologic testing. So this is probably the cause of all of those positive autoimmune results. Finally, in terms of his decompensated cirrhosis, hepatology did get involved. And hepatology did start the liver transplant evaluation while he's inpatient, especially because he was going to miss that appointment. And also they agreed with increasing his diuretic regimen. And so now they've actually got him up to 150 of Spiro and 60 of Lasix. And hopefully that is going to be enough to help prevent him from reaccumulating his ascites and the pleural effusion and other signs of volume overload. All right, so that is the presentation of this patient. Definitely some bread and butter cirrhosis topics here, and also a little bit of some mild twists and some question marks as well. And we'll have to see how this patient does, but I hope this was a useful video for you guys to go through the exercise of going through the patient's history, their medications and their vitals and their results, and then trying to generate your own problem list, and then coming back and looking at the results of things you ordered to see and reevaluate how the patient's doing. Let me know if you like this style of video and if you want me to do more like this. Hope you guys enjoyed this one. I'll see you in the next video, and peace.